Are we live now, Rohit?
Sir, we are not live yet. We are live in next 15 seconds, sir. And I
Okay.
will also inform you, sir. Sir, we are live now. Good to go, sir.
Okay. Thank you, Rohit. Very good evening to all the doctors and all the participants. Intas Women Health welcomes you all to this interesting masterclass series. The series is As Blues. As Blues is on sexuality and sexual health. And trust me, this is going to be an interesting series. Looking at the faculty today, we will not only have the learnings, but it will be a perfect blend of humor, a blend of ghazal, shairi, and some philosophy, some interesting case studies. So overall, it will be a very good learning experience for all of us. And I just cannot wait to see it further. So today we have very expert moderators with us, Dr. Neeraj Jadhav, who is heading the chairperson of Foxy Sexual Health Committee, and Dr. Apurva, who is handling the public relations of Foxy Sexual Health Committee. This is an unique initiative from Foxy Sexual Health Committee. So please keep in mind, you will get one ICOG credit point in each session. Today is session 1. We will be having session of 6 master classes. So looking forward to have an exciting time ahead. And now I would like to hand over the stage to moderators of the day, Dr. Neeraj Jadhav. So requesting Dr. Neeraj Jadhav to take the charge. Over to you, sir.
Thank you, Lai. Sexual Medicine Committee welcomes all the delegates present in this masterclass series, session 1. And we have doing this webinar since last 1 year in the different parts of India with the different societies of our societies. And one thing we understood there is a trust for the knowledge of the sexual medicine, but there is no enough guidance for many of us gynecologists. Where should they learn about the sexual medicine? So we come with this idea of a masterclass series in sexual medicine, where we will take only one topic at a time and discuss it thoroughly so people can understand about it and they can manage such type of patient in their clinic. So I'm thankful to our president, Dr. Alpesh Gandhi sir, and my vice president, Dr. Ragini Agrawal, and our secretary general, Dr. Jaideep Desai, who gave permission to us to conduct this masterclass series. And we are fortunate for our first session as a chief guest, Dr. Alpesh Gandhi sir is present with us, and I request him to say a few words about the Foxy and the sexual medicine overall. So welcome, Dr. Alpesh Gandhi sir.
Thank you, Dr. Neeraj. At the outset, I would like to extend warm welcome to all of you on behalf of Foxy and the Sexual Medicine Committee Foxy. A very good evening to all of you. I would also like to congratulate Dr. Neeraj Jadhav and Team Sexual Medicine Committee for the excellent work for organizing webinars continuously, for updating knowledge of our members, for the publications and so many activities conducted in this difficult time of COVID-19. We believe that sexuality is an important aspect of health, which can impact the overall well-being of men and women. Disorders of sexual functioning are common among men and women of all the ages and cultural backgrounds, but it is less discussed, less research, and ignored public health issue in India. Sexual dysfunction is a difficulty experienced by an individual or a couple during any stage of a normal sexual activity. including physical pleasure, desire, preference, arousal, orgasm, and others. It is estimated that 21.15% of male and around 14% of female have one or more sexual disorders. And this study concluded that 1 in 5 males and 1 in 7 females were suffering from one or more sexual disorder. I congratulate Dr. Neeraj Jadhav for starting this masterclass series of 6 sessions. And today we have a session on a very important topic, hypoactive sexual disorder, desire disorder, HSDD, unraveling the enigma. Hypoactive sexual desire disorder is hypersexuality or inhibited sexual desire is considered a sexual dysfunction and is characterized as a lack of or absence of sexual desire or sexual activity as judged by a clinician. It is one of a, it may be one of a common problem of all the time. It is happening in certain, it may happen all the time or it may happen in certain situations. Foxy as a responsible body is concerned about the health and safety of women. Foxy has different cells working on different projects, and Sexual Medicine Committee is one of the 27 subcommittees of Foxy, who is working tirelessly for the health and safety of women of India. We all need to learn the basic of it. It should be included in the curriculum of undergraduate, improving the training of undergraduate medical students in sexual related issues, increasing trained individuals in sexual medicine by required courses, and providing sex education to the general population using media and other possible ways are likely to play a significant role in addressing the increasing sexual health morbidity, and uh, it may solve the problems and the public health issue. Wider recognition of this issue is needed among the healthcare providers, policymakers, and all the practitioners like us. Today, we have very eminent faculties, Dr. Deepak Jumani, Dr. Sunil Jindal, Dr. Anita Syam. We are thankful to all the esteemed faculties. They are very eminent, very expert, and I would request all the delegates to take benefit from their experience and their knowledge and expertise. And I also would like to thank Dr. Neeraj Jadhav and Apurva, who are the moderator of today's program. I wish grant success to this program. And once again, I would like to congratulate Dr. Neeraj Jadhav and Team Sexual Medicine Committee for taking this committee on a new height and really working tirelessly and making many of our members interested to work for this committee, and we can say changing the previously not much members were interested for this committee, but now we can say there is lots of interest have been generated across India to work for this committee. So I would once again congratulate Dr. Neeraj for continue doing this good work. I wish grant success to this webinar, and I wish happy learning to all of you. Thank you very much for giving me this opportunity. Thank you.
Thank you, Alkesh sir, for your nice words, and it will be very encouraging for us to do more and more work in the field of sexual medicine of Foxy. So now I invite my co-moderator, Dr. Apurva Kumar Datta, to introduce our three masters. Today we have three masters, and we and Dr. Apurva is the students, so they will teach us. We are behalf of the attendee, we are the two students, and we have three masters. So kindly introduce our masters, Dr. Apurva.
Thank you so much. First of all, thank you and welcome to Alpesh sir. Thank you for always blessing us and always encouraging us. Today we have very eminent and very well-known faculties with us. They don't need any introduction. First, I would like to welcome Dr. Deepak Zumani sir. Zumani sir is the senior sexual health physician and counselor. Dr. Sunil Jindal sir, welcome sir. Sir is the chief consultant, laparoscopic surgeon, andrologist, and sexual medicine expert at Jindal Hospital. Uh, Welcome to Anita Shyam ma'am. Anita ma'am is integrative psychiatrist, clinical sexologist, and sex coach. Welcome and thank you for accepting our invitation and giving your precious time for this wave series. Over to you, Neeraj sir, to start the session with the first question.
So without much wasting much time, we will go directly to the question. And today's first question for Dr. Sunil sir. Can you explain, sir, what is the desire?
So first of all, I would like to share the slide.
Yeah.
Yeah, thank you very much. And thank you very much for organizing this great webinar, because of the reason that about 40% of women and about 30 to 35% of men suffer from the problem of sexual medicine. And if we look at a disease or a problem which is there very deeply ingrained in human beings, which affects relationships, psychologically, the whole human being as a whole, in such a massive population, which leads to so much of marital disharmony, and still people do not talk about it, do not discuss it, do not treat it as medicine. And this leads to so many, the previous slide please, this leads to so many issues, because of which Dr. Neeraj Yadav, with of course the blessings of Dr. Alpesh, planned to create this great and beautiful program of 6 master classes, which would be spread across 15 days each. And at the end of 3 months, just by spending about 2 hours in 15 days, the whole of sexual medicine would be covered, which can be so beautifully utilized for our patients. In fact, if you ask me, very honestly, we never were perfectly trained for this line. But since we have been doing fertility treatment for the last 24 years, it became a situation where a lot of patients, young patients, educated patients with marital disharmony came to us. And they came to us with problems which actually were sexual. And then getting into this line, my wife is a gynecologist, I'm an andrologist, but then both of us treat sexual medicine. And getting into this line, we realized that such an interesting subject for everybody, all of us, is so much ignored by all of us. And therefore, it's most important for us to understand sexuality. So sexuality is a very interesting and a very complex and the most important driving force of human beings. And this has a component of relational, anatomical, physiological, psychological, development as we grow as a child, cultural. The way we culturally are brought up is the way our sexuality is. Sexuality in the West, sexuality over here in India, sexuality in the Middle East, sexuality in countries which are purely Islamic is very different. And all this is different because of the cultural beliefs. And most important, sexuality is completely relational. If your partner is different from you, then your sexuality also gets affected gravely. A lot of women who are hyposexual or have pain disorder, their husbands develop secondary erectile dysfunction, though they don't have actually erectile dysfunction. This is the way sexuality becomes relational. Next slide, please. Now, I'd like to just bring in before this masterclass, and of course, it's a part of desire, that there are 7 components of sexuality. And these 7 components are, number 1, gender identity. Gender identity would be, I'm born as a man, and my biological identity and my gender identity is that of a man. Then next comes orientation. My orientation is heterosexual. It is not homosexual, it is heterosexual. And along with that, my intention. These three things together give me a sexual identity on which my sexuality is dependent. And similarly, it is for every patient. Along with that, then we come to the sexual function. And the sexual function has a few components. And the sexual function has desire, arousal, orgasm, emotional satisfaction. Now let us understand one small thing. All these things are completely related to our partner's sexuality. So it is not that it's a kind of a game where you don't play the game alone. It's a game where your partner plays the game with you, and you are in as good in this game depending on how your partner is. वो बचपन में गेम खेला करते थे ना हम, वो लंगड़ी टांग वाला जिसमें बीच में टांग बंधी होती थी, ये वही गेम है. And that is the reason it's so beautiful, it's so complex, and it is so mysterious. Next slide, please. So when we go into desire, we need to understand desire is not as simple as we think it is. And desire mainly has three components. The first component is the sexual drive. So the sexual drive is the biological drive, the kind of drive which a human being has and which we see so often in animals. I mean, if you see an elephant go must, if you see any animal, be it a monkey, be it a dog, be it a cat, be in sexual drive, that is a part of the desire. The second is the sexual motivation. Now, supposing as a human being, you meet somebody who is very attractive, you have the innate sexual drive, and psychologically you feel this is the place for you. That's the moment where sexual motivation takes place. And the third is sexual wish. This is social. Now, please understand, you may be having a desire, but the desire is not everywhere. It is not in every relationship. It is not with every human being. It is not with every human being you know. This is because sexual wish is social. So three things get together: the sexual drive, the motivation, and the wish. And these three together bring in the desire. And this is produced by the endoneurocrine mechanisms. Next slide, please. Now, I would over here definitely like to say one small thing. People confuse love and desire. Love is very different from desire. Love is security. Desire is insecure. Love is when you together would like to create something as some time together, while desire is the unexplored. So what happens is we get so many patients who say we love each other phenomenally, but we do not have sex. We cannot live with each other, but we just initially did not have sex because of some problem, and now we don't want sex, which is not correct. So we cannot confuse love with desire. Now let us look at the endocrine network. Our brain has the prefrontal area, and in this area, there is a lot of play of chemicals which goes on. So when a woman or a man sees a woman, when a woman sees a man, the first thing which rises in her is dopamine. And dopamine is like addicting, like, well, you could say cocaine. And it is so high that this dopamine is what is it when people say that desire is there. But this dopamine is controlled by a few hormones. So the hormones which lead to potentiation of dopamine or testosterone in man as well as the woman, melanocorticoids in man as well as the women, and estrogens and progesterogens directly affect the desire. But there are few drugs which actually decrease desire. These are prolactin, serotonin, and all the opioids or all the cannabinoids. So those people who take cocaine or take marijuana or use drugs, these people have normally an affected desire. So whatever anybody may say that after taking these drugs, they have become crazy, but the story is different. They have affected desire. Next slide, please. So the sexual response cycle, the phase 2 is, which is important because after desire, what would come in is the arousal. So the arousal which would come in them is, which are the anatomical changes which happen during the, after the desire. And these normally are vasocongestion in women, which leads to vaginal lubrication, clitoral tumescence, and labial color changes. There's increase in heart rate, blood pressure, respiratory rate, and a lot of muscles function differently. So arousal is a different thing. The human being knows that arousal is there. And arousal has psychological stimulation and also a physiological stimulation. And arousal takes place both in men and women, which is based on desire. And we're all discussing this today because further on, Dr. Deepak and Dr. Anita, along with me, are going to unravel the whole story of hyposexual female disorder, which is there in up to 40% of Indian women. My goodness, 40%. No disease is there in 40%. Though I won't call it a disease really, but I'll call it a situation which needs to be corrected in human beings for their relations. So that's the way normally the physiological and anatomical changes will take place after desire for arousal. Then, of course, after this, which is out of the purview today, is the orgasm and the emotional satisfaction. But this whole is going to form the sexual response cycle. Apurva.
Yes, yes. Thank you so much. So elaborated everything about the desire in so simple words. Now we're moving to our next question to Anita ma'am. Ma'am, would you like to share the slides? Anita ma'am?
Yeah, stop sharing.
Yeah.
You have to
Anita
unmute,
ma'am,
Dr.
are you
Anita.
there? Yeah.
You have to
Now
unmute
you can share your slides, please.
Yes, I think
Ma'am, questions to you is, what are the type of desire disorders? Can you just elaborate it, ma'am?
yes. Thank you. Can you see my slides? Yes. So thank you so much, Dr. Jindal. You made my life easy today. So thank you so much. It was a very good, elaborate description of desire, arousal, and which is a very important part of a female functioning or a male sexual functioning. But something which I would also like to bring to your notice is about the response cycle. And what happens in an individual, especially a women. Women are very prone to have adaptive desires or responsive desires. So if you see this cycle specifically here, a desire starts with a sexual neutrality state. A stimulus is introduced, which is more psychological or it can be visual, and that can act as a sexual stimuli, and that can lead to arousal. This is called the non-linear model of a sexual response cycle. So initially, why this is important to us? Because initially it was thought that sexual functioning was a very linear process. It's desire, it's arousal, it's orgasm, it's resolution. But thanks to Dr. Basin has brought a very important aspect that not necessarily a woman needs to have desire to be involved in a sexual behavior. It can be a response to the arousal. And when a woman is aroused, she can have desire. and then the cycle continues. So if you get a chance, friends, do look at these three different diagrams, which are very important and can really give you a good understanding of how a response cycle works in a female. So, and as Dr. Jindal mentioned, that it is a very common condition, friends. It's a very common condition. Women involved in relationships, women not involved in relationships, low desire, hypoactive desire is a very common condition. And I'm glad today we are talking about this. Now, just again, giving you a brush of how are the sexual disorders classified? We have three basic organizations: the DSM-5, which is the Diagnostic Statistic Manual, the fifth version, the ICD-10, which is the International International Classification of Disease, the 11th one has just been released, and also the ICM, that is the International Consultation of Sexual Medicine. These are very important because they kind of give you guidelines. They kind of give you a brief idea of how you can diagnose these conditions. As much as I want to say the word diagnosis, but I truly don't believe in diagnosis, especially in sexual medicine, because we all are not diagnostic codes. We are human beings and we work differently, but these are available. Now, according to the DSM-5, the female sexual dysfunction, this was the earlier version where it was classified into the hypoactive sexual desire disorder, the sexual arousal disorder, and the sexual aversion disorder. Now, the recent version of the DSM-5 has clubbed this together. And the reason to club this together is based on the non-linear model, because if the sexual functioning doesn't work linearly. If there is arousal, there'll be desire. If there's desire, there's arousal. So thanks to DSM-5, they have clubbed this functioning as female sexual interest arousal disorder. And just for the sake of understanding, there's also female orgasmic disorder and genitopelvic pain disorder. But for today's presentation, let's, friends, focus on the desire aspect. So now when we talk about the hypoactive phase, the arousal and aversion, we're going to club it together to say female sexual interest arousal disorder. So again, not necessarily that a person is born with no sex, as Dr. Jindal just mentioned, that we are all sexual beings. We are born to love self and love others. And so DSM-5 brings to us that these disorders don't just go stigmatizing, don't go diagnosing, because you need to understand how these disorders really come into play. So people might have a lifelong hyposexual disorder or a desire disorder, or it can be acquired. Somebody who's never had a normal sexual functioning will be called as lifelong. These are various specifiers. It could be acquired. It just he or she was having a normal sexual functioning, and something happened in life, and these challenges happen in their life. It can be present in all the situations, that is generalized, global, or it can be situational. It can be with some particular partner. It can be in certain places. It can be mild, moderate, severe. And also it can be associated it can be secondary to a physical problem, a medical issue, a substance or an recreational drug issue. Somebody must be having a psychiatric diagnosis already, or psychiatric or psychological issues, and also medications. So these specifiers really help you to make a proper diagnosis and help you to formulate your interventions. So I'm just going to run through this, like why is it really important, and what is the differentiation between these diagnostic tools. So ICD-10 basically just follows the linear model of the sexual response. The DSM-5 focuses mainly on the non-linear model. That's why they clubbed them together as an interest and arousal disorder. And it is also, DSM also focuses on the relationship distress. This condition should definitely cause some distress to this couple. And that is when it's going to be under diagnostic umbrella. Okay, friends. So whenever you get a chance, look at this slide. It gives you a brief introduction of why the ICD-10, ICD-11 and the DSM-5 are different. And there's another diagnostic we just mentioned about the ICSM, that is the International Consultation of Sexual Medicine. They have their own criterias about diagnosing and about coming up with diagnostic codes. So I'll just brush through that. Now, specifically talking about hypoactive sexual desire disorder, that is the interest and the arousal disorder. How would you know that this person really has an low sex desire? So according to DSM-5, they say a present of any of these three following characteristics will help you diagnose if this person is really having low sexual desire. So here we have absence or reduced interest in sexual activity, absence and reduced sexual or erotic thoughts or fantasies. There is no or reduced initiation. The person doesn't want to be initiated in any type of sexual behavior. And again, not just be initiating, is doesn't want to respond. So those are two different aspects we have to know, that initiation, getting ready or wanting to be involved in a sexual behavior or a sexual act, or also ready to accept. Maybe my partner is sexually aroused and want to be involved in sex, but I don't want to do anything with it. Low sex desire. Absent, reduced sexual excitement, that is lack of arousal. A sexual excitement, pleasure during sexual activity in almost all sexual situations. Absence or reduced sexual interest and arousal in response to any internal or external sexual erotic clues. There are clues, could be you're watching movie, I don't feel aroused. I'm looking at pornographic magazine, I don't feel aroused. That is low sex desire. And again, here we come some arousal symptoms. Absence or reduced, oh, I'm so sorry. Absence or reduced sexual interest in response to any internal external clues. Absence or reduced genital or non-genital sensations during a sexual activity. And so it shouldn't be like somebody comes to you and, oh, last week I didn't want to have sex, and looks like and this person has a low sexual desire. No, manifestations have to be shown at least for a period of time to have a proper diagnosis. And DSM says minimum 6 months. And a quick brush on lack of motivation for sexual manifestation by either reduced or absent. We talked about spontaneous desire or responsive desire. And just again to emphasize on these symptomologies or these diagnostic signs and symptoms, there should be a significant distress. So in my so many years of practice, I have realized that there has to be a significant personal distress to the couple, that they come to you, and then you can say, okay, yes, they have some issues happening with sexual dysfunctioning. But most of the time, if there is according to these criterias, if there is no frustration in the relationship, there is no grief, there's incompetence, loss, sadness, or any of these symptoms, then it's pretty much, you should not be diagnosing them. They need more of psychoeducation. And Dr. Jindal just mentioned about this, but let me tell you, so hypoactive sexual desire disorder or lack of interest and arousal could also signify the relationship of the sexual excitation or the inhibitory process. Something very important to realize, and I'm going to discuss more in detail. So sexual excitation, a woman has to be really aroused to be involved in a sexual behavior. So if there is no excitation, there is no communication, there is no visual stimuli or physical stimuli, and there is more inhibition. Now, what does inhibition really mean? I had a patient a couple of years ago, and they came to me that my wife doesn't want to have sex. I'm like, okay, so what's really going on? And the patient says, can you just prescribe some medication? I'm like, let's go a little bit more deeper of what's happening here. And it turned out that there was more of inhibition rather than more of excitation. Why? Because the husband was an alcoholic. The husband was involved in there was an abusive relationship. So when you look at, there's more inhibition, she is not going to be ready to be involved in a sexual act or to be intimate with this person. So there has to be a balance, friends, a balance of excitation and inhibition. A woman has to be properly excited. The relationship has to be a very lovable, fruitful relationship, and then the involvement of intimacy happens. Dr. Jindal mentioned about this, about the three components of desire. So it's not just very biological. I give the patient testosterone and boom comes the desire. So it just doesn't happen like this. And thanks to Dr. Jindal for bringing up the three components of desire. And, and I just mentioned about the responsive desire. It is known in our culture, friends, that women usually do not go and say, hey, come on, I want to have sex. She wants to be loved. She wants to be touched. She wants to be hugged. So when these things, these different aspects of intimacy happen, and that's where she responds to be involved in a sexual behavior, and that is the responsive desire. We just talked about an adaptive response. Now, come down the line of so many years of practice, women will come, especially the men will come, and I have low sexual desire. My wife has a low sexual desire. And with proper history taking, you'll get to know it becomes an adaptive behavior. Husband is working 6 months abroad. She's not had sex in last 6 months. It's an adaptive response that she's not, husband comes home and boom comes the desire. No. Husband has erectile dysfunction. He expects the wife to be having a proper sexual desire. No, because this is affecting her arousal, this is affecting her orgasm. And so these are called the adaptive response. Very important topic, not talked about, not much researched about, is sexual aversion. And I'm going to explain that why we are talking this today, because a lot of aversion clients will come to you with low desire, because they actually have an aversion towards having sex. And the reasons could be, we're going to discuss, but the reasons could be right from a small reason that my husband's sweat smells a lot. Okay, I have an aversion. Oh, I had a very bad trauma. I was raped as a child, or I recently had a rape. So they kind of come together, and as a clinician and after today's class, hopefully my friends would be able to distinguish with proper history taking and proper understanding of these two components. So sexual aversion disorder has been scrapped from the DSM-5, but DSM-3 says persistent or recurrent extreme aversion to. So it's an aversion and avoidance. So there's an aversion and avoidance of all or almost all genital genital sexual contact with a sexual partner. Symptoms had to not be better accounted by another diagnosis. So it doesn't has to be a part of a diagnosis of depression or a diagnosis of schizophrenia. It stands alone. So there is a persistent, recurrent, extreme aversion and avoidance. Now, why is it so important? Because in this condition, in this aversion disorder, the female would have fantasies, would have desire to have sex, would be masturbating. So it's not that she doesn't have the desire, but because of an aversion, because of the aversion and avoidance of any sexual contact, she might come to you as no sex desire. But actually, that's not the case. If asked, if detailed history is taken, she would be masturbating, she would be fantasizing, she would be involved in watching pornography, sex. So it is a very important thing also to notice. Okay.
Thank you.
Okay. Now, since the aversion disorder has a component of anxiety and phobia, it is a debatable thing whether this can be lifelong, because we all know we are born very sexual beings. We are born to love each other. So aversion is an experience which comes as a conditioned response. And I'm going to dig more deep into this as we talk. So it is an acquired response. Something happened in life. The trauma keeps on coming to your mind, and the person is not involved in having sex. So this person is kind of caught into a vicious cycle of avoidance, which becomes reinforced with being an avoidant and aversion. And that behavior keeps on going on. So it's a vicious cycle of avoidance, negative reinforcement, and avoidant behavior continues. So as if a person comes to you with this diagnosis, it is very important that the psychologist kind of digs into the history and helps in breaking this cycle if you want this female to be involved in sexual behavior or intimacy. And interestingly, aversion disorders can be very situational. Not necessarily it's always there. So if this client is involved in intimacy with the husband, but as soon as he is drunk, he is in a very, if he has bipolar and comes and shouting in the house, beating, abusive, he's going to show an aversion. So situational SAD, that is sad, sexual aversion is specific to a certain relationship, and that outside of that relationship, the person must be functioning normally. So keeping in mind, friends, aversion is very conditional. It is acquired, and it is situational. And it can, of course, it can be global also. It's just depending on what this female is going through. It can be present generalized. This is just quickly. It is seen that the aversion is primary. A primary aversion disorder is seen more in men, and secondary is seen in women. And now there is a diagnostic dilemma, because you will be like, okay, so we have two disorders here coming into picture. We have low sex, female interest and arousal disorder, and we have aversion. How do you differentiate? And luckily, the DSM-5 has put it together, so you don't really have to worry. You just have to follow the diagnostic criteria. But why is it so important, friends? So I just mentioned to you the differences between the hypoactive and the aversion is low sexual desire will be present in the hyposexual disorder, and the person with aversion will have sex, will want to have desire to have sex, but because the aversions, he or she might avoid and show an aversion to the behavior. So also to remember is the post-traumatic stress disorder. So DSM-5 has their own criteria for post-traumatic stress disorder. So let's not mix around, because a person who has post-traumatic stress disorder would need a psychologist who works with trauma. But people who have aversion or people who have low sexual desire would need professionals like us who deal with sexual dysfunctioning. So that's why it's very important to know what are the two differences. Now, it has been noticed that individuals with aversion disorder have discussed as a very critical component. And as physicians, we need to be aware of what are the differences between the low sexual desire and aversion. So there has to be a discuss, like we said, discuss an anxiety and fear as a component before we diagnose. Now, there is also an overlap. There's overlap of aversion disorder, because if an individual has vaginismus, the pain, the genitopelvic pain will not allow this person to be involved in sexual behavior. So this becomes like, if a person has vaginismus and you've diagnosed this client with aversion, you will kind of miss the diagnosis and will not be able to really treat vaginismus, and the whole thing can be misleading. So when you are diagnosing somebody, or you are talking to an individual who comes to you with either an aversion or a low desire, you want to dig into the history of, is this person has genitopelvic pain disorder? Okay, does this person have enough arousal that is leading to these conditions? There is also an overlap between sexual aversion and phobia. Not lot of research has been done. Can that be a phobia? But not necessarily, because a phobic disorder would definitely have the anxiety and fear. For example, we have somebody who has a phobia of insects. But when we read literature, Kaplan very clearly mentions spider is not the necessity to live, but sex is. So these are the differences we need to know. That is this specific phobia? No, it is definitely an aversion disorder to sex. And since the systemic desensitization therapy and behavioral therapy have been very helpful with aversion disorders, it kind of becomes very significant that this is not phobia. And you can also read the slide if you want more detail. And since Aversion disorders are not diagnosed because of lack of research. There is no much data available. A client will silently suffer. And sometimes the client would feel, I don't, maybe a physician doesn't understand what I'm going through. And that's why there's no help available. And that's why they would not be approaching a professional. So as a professional, we need to be aware of these conditions. And if you have a client come to you with sexual dysfunction or any challenges which they are facing in their sexual life, you might want to dig into more of their history, more of gathering information on signs and symptoms of them.
Thank you. Thank
Now,
you. Yeah. You were.
sorry.
Yeah.
Okay.
No, go ahead. Go ahead. No problem.
So keeping now, uh, this is something which I have to cover as well, though. Quickly, the etiology and the risk factors of sexual dysfunctioning, we have specifically mentioned here the hypoactive sexual disorder, desire disorder. But a very popular model right now is the bio, psycho, social, and recent terms have been added spiritual. So when you keep in mind about the biological aspect, what can lead to the desire function, the psychological aspect, that is the mental functioning of this individual, and then the social aspect, the beliefs this person has about sex, what has been ingrained in this person's mind for such a long time, and the spiritual belief. So that recently with the three models, we have added the spiritual model also. So when we talk about what causes these challenges in an individual, it can be psychological, and Dr. Jindal covered this so very well that I really don't want to go. But when a client comes to you with certain sexual challenges, friends, you really want to dig to find out whether it's an organic condition or an inorganic condition. And organic meaning, does it have a medical, hormonal, surgical issues, or it can be dealt with simple psychotherapy. That says it can be a psychological problem, relationship problem, or somebody dealing with just a social aspect of it. So again, somebody on just to add, what are the hormonal changes happening in this person? And women tend to show a lot of fluctuations. Menses come, they don't want to have sex. Ovulation time, changes in the sexual behavior. Menopause, sometimes even the role what a woman plays, she is juggling all throughout the day, being a mom, being a sister, being a mother, being a partner. So that stress can also be an etiological factor, and you have to keep that in mind. Somebody having a stressful time at office would definitely affect their sexual behavior. So keeping those things in mind, that premenopause, menopause, estrogen, organic conditions like diabetes, like hypertension, all these can affect their sexual functioning or wanting to be involved in intimacy. Something which I really want to bring to your notice is body image issues. Women are always concerned about how they look, how their body structures are. So as a very intelligent physician, you want to know if this person has any body image issues, and is that what is stopping her from being involved in an intimate relationship? I am too thin, I am too fat, I don't have enough boobs, I don't have enough butts. So a physician should also look at those psychological aspects when diagnosing a client. I just mentioned about aging. The various hormonal changes can lead to a different functioning of the sexual behavior, high desire, low desire, or even sometimes aversion. Now, why do I say aversion in an aging client? For instance, friends, somebody who has got a surgical oophorectomy, or somebody who has surgically pushed into menopause or menopause, this client is definitely going to have dry vagina, and intercourse would be uncomfortable. Dryness of vagina can be very painful, and that can lead to aversion. Okay, somebody lost her husband, somebody's husband living far away. And I specifically say husband because we are talking about female sexual desires here, or female sexual dysfunctioning. So those aspects have also, or etiological factors should be kept in mind when we are talking the age, the hormonal issues. What lifestyle changes has happened in this person's life? COVID has not been easy with many people. COVID has brought a lot of changes in sexual functioning, in relationship. Women are very prone to depression. So is this person depressed? Because if the major diagnosis is depression, of course she is not going to be involved in an intimate relationship, because that is the wanting of this disease. Any chronic illnesses involved, diabetes, hypertension, hormonal issues, difficult relationship. So all these etiological factors can affect somebody's sexual functioning. We just talked about the psychological aspect. You can read whenever it's there. And that brings us to Dr. Deepak. So thank you so much.
Thank you, Dr. Anita.
Okay.
So now our next questions to Dr. Deepak Jumani sir. Can you tell something about the epidemiology of the HSDD, pathophysiology of HSDD, and what are the symptoms of HSDD? Dr. Deepak Bhai, we want to
Pranams to my
know
team,
about.
Dr. O.P. Kapoor, Dr. Prakash Kothari, and Dr. Sushant Joshi. I beseech them to be my sunshine and bless me always. I have some disclosures. I'm not responsible for Section 497 verdict. My patient, he said, was told by his girlfriend that now Article 497 is off. But then he said, now it's too late. I'm old now. But then, on second thoughts, he told him, let me ask Dr. Juman. Of all the human urges, the urge to have sex is the strongest. Sex, as we all know, is God made, but restrictions are man made. Women don't talk about it. They're all tight-lipped. They consider it to be sin. They've been told that it's dirty, bad, and it is to be done only when you get married, only with your husband. You shouldn't do it. And for long, we know that women were culturally pressurized, undoctrinated with the male-centered idea that sex must always end in intercourse, otherwise it's not real sex. And so many things which are there, which have been put into the minds of women, these things. And look at the research. In India, we have got 34 registered medical studies for erectile dysfunctions and only 4 studies for female sexual interest arousal disorder. See the difference. There has been an avoidant. It's the women who sometimes don't want it, they avoid having sex for various reasons. So it's the duty of we physicians to break all the barriers and come over clinical inertia and ask our patients about these sexual dysfunctions. So the onus of sexual health of our patients lies with we physicians. Now let me give you the prevalence and the epidemiology of the hypoactive sexual desire disorder, which has been asked for. A beautiful survey said 62% of women admitted that they were not satisfied with their sex lives. 50% of married couples in Japan don't have sex, they are living sexless. 1 in 10 pre-menopausal women across the globe suffer from hypoactive sexual desire disorders. This is a Mayo Clinic consensus with the International Society for Study of Women's Sexual Health Process of Care for Management of HSDD in women. They say that this could be due to 3 reasons, the assessment. One is either due to the definition, which is low desire or interest, or it could be in the group of participants which were included in it, or third would be due to certain methodology which they tried. In the prevalence of female sexual problems associated with distress and determinants of treatment seeking, this is study, precise study, a widely cited large population study based on 50,000 women in the United States, of which 31,000 women completed the whole study. 63% was the response rate, and the age of this women were between 18 and 102 years. What they found was the low desire was the most common sexual problem reported in 37.7% of participants. Low desire with distress was present in approximately 10% of women and was more common than distressing other sexual dysfunctions, which are arousal or orgasmic difficulties. Other study proved that HSDD was present in 8.9% of women from 18 to 44 years, 12.3% from 45 to 64, and 7.4% for women over 65. Less than half of the patients with sexual problems seek help from or initiate discussions with physicians. Patients are inhibited by fear of embarrassing the physicians and believe that physicians should initiate a discussions. This is the best tool, the decreased sexual desire screener, which is helping us in detecting and diagnosing HSDD. Associates of HSDD are multiple. It's already been discussed by Dr. Anita and Dr. Jendal. At the beginning of marriage, every wife treats her husband as God, Pati Parmeshwar. This is truth. But soon, after some time, I don't know what happens, the words change. What is the difference between a woman and a man? A woman wants one man to satisfy all her needs. But a man wants every woman to satisfy his one need. Look at his desires. Every wife today is proven that's a mistress for her husband. Miss for 1 hour and the stress for the rest 24 hours, 23 hours. Friends, life has become like a pen, is simple, soft, and straight. It's women who make it hard. Now, James Prescott, the famous developmental neuropsychologist who studied 44 cultures across the globe, he came out with his inference of his lifetime work that our brains have built-in reciprocal relationship between violence and pleasures. So if you want to decrease the violence in your life, increase the pleasures. And the power to give pleasure is the greatest power we all have. But the difference is that men and women tend to experience the desire of pleasures in a different way. Why do women have HSDD? What is the reason? If there is a painful disorder, it will lead to having less sex or no sex. If she has an orgasmic disorder, she doesn't enjoy it. It will have, again, HSDD. If she cannot get aroused, she will have HSDD. But if she has HSDD, she would either get pain or have orgasm or arousal. So it's a vicious cycle with all the various domains of sexual dysfunctions. Two assumptions which guide us in this field are: one is the genital physiology is sufficient to define as the normal sexual function and dysfunction, and second, subjective sexual experience is the gold standard for assessment and treatment. So we therefore assume a woman's perception of her sexual and physiological functions are complementary sides of the same coin and can guide us to diagnose and treat female sexual dysfunctions. And friends, let me tell you, it's not the sex that gives you pleasure, it's the lover which gives you the pleasure. And we have this cultural myth. All men think they are all phallocentric. They presume all women only need and must enjoy sexual intercourse. That is what they feel. This is wrong. Women have health issues right from womb to tomb. It has been known, whether she's a toddler or she's grown up going to school, or she gets married, or she's a sister, she's got responsibility till she becomes a grandmother or a senior. She has challenges throughout her lives during her age continuously. Now, we all are going to live long, more than 70 years. And most of the women are going to spend their most life after 50 years. The most beautiful life of their life is going to be after menopause. So we need to understand how their pleasure would be, how their desire should be there and all that. So physiological changes associated with aging, coupled with increased prevalence of medical disorders, be it metabolic or anything, play a significant role in the pathogenesis of most of the sexual dysfunction, including HSDD. Testosterone and free testosterone don't change, they remain unchanged or maybe increase, but the intracellular androgens change, decrease, and estrogen deficiency may cause local symptoms and can have indirect effect on sexual enjoyment. Now let me give you a deeper perspective of this. The science behind hyposexual desire disorders, they did MRI, functional MRIs, and they found that there were certain areas of the brain which were deactivated in patients who have HSDD, both in the right and the left brain. And in patients who had no HSDD, the areas of the brains were highly marked and there was more blood flow in them. to understand why this happens is we should understand the tipping point model, which is beautiful. It explains to us that there are certain inhibitory factors and certain excitatory factors. Now, these could be hormones, it could be neurotransmitters, it could be physiological thing, it could be psychological things. So the current understanding of what excites a woman or what gives her a turn on is dopamine, norepinephrine, melanocortin, and oxytocin, and two hormones which are estrogen and testosterone. And the things which inhibit her or put her on turn off thing are serotonin, prolactin, opoids and cannabinoids and progesterone. So this is what we need to understand, and there has to be a proper balance between the two. Along with this, there has to be physiological and organic issues, psychosocial, cultural and behavioral issues on both the sides, which can inhibit or excite them. So sexual tipping point has to be understood. It is variable and it is dynamic. Prefrontal cortex get activated in patients who have HSDD, and this leads to increased inhibition of sexual desire disorders. There are certain psychological conditions which potentiate impacting desire, and amongst them the common is depression and anxiety. A beautiful study said that 33% women with depression developed sexual desire. Along with that, there could be poor body image, stress, history of abuse, substance abuse, self-imposed pressure for sex, religious, cultural beliefs, relationship factors, lifestyle factors, fatigue, sleep deprivation, and certain sexual factors. There are certain male factors which are responsible for these things. It could be low desire in men, it could be erectile dysfunction and ejaculatory disorders. Medical conditions potentiating impacting desires, amongst them the most common is depression and relationship factors. There could be coronary artery disease, hypertension, diabetes, metabolic syndrome, thyroid disease and many others. As we age, we need to understand that we have cardiometabolic risk factors, our androgen levels decrease and estrogen levels in women also decrease during menopause, as we have seen. And there are some women who undergone hysterectomy and oophorectomy. These patients also develop hypoactive sexual desire. Now, we know what happens. It is physiological, it is cognitive, and of course, it is behavioral. This is what includes in the desire thing. And these are the questions which we ask because these are the patients who manifest us in these forms. They don't have sexual thoughts. They don't have sexual fantasies. They're not interested in participation in the sexual activity. They don't initiate the sexual activity and they are not receptive to the approach of the partners. So these are the symptoms. These are the questions we ask that do you get sexual thoughts or do you get fantasies? Are you interested in your sexual activity? Who initiates the sexual activity and who are you accepting your partner when he approaches you for a sex? I'll end here. Over to you, Apurva.
Thank you so much, sir, with those colorful slides and briefly you have in a simple way you have explained everything, the symptoms, the desire, the epidemiology. Moving to our next question, Sunil sir. Yeah, Sunil sir. Yeah. After we are learned about what is desire, what is different type of desire, pathology, physiology, symptoms, and almost everything. Now, after knowing everything, now it's the time how to diagnose it, what is the treatment and what is the other things. So, question to you, Sunil sir, what is the importance of the history taking and what history actually is important for taking this? And is there any questionnaire, like in many of the sexual things, we have the questionnaire pattern. We have like tuck tuck tuck, ask this question and you will find that these are the patient is suffering from this and this is the treatment. So what is the importance of the history taking? What the things which are asked in the history, and secondly, what's the questionnaires? Over to you, Sunil sir.
Thank you very much, Apurva ji.
Yes,
And it's been so wonderful to have Dr. Neeta Sham and of course Dr. Deepak with us. Dr. Deepak of course has his own style and Dr. Neeta goes deep into the subject. पर मैं कभी-कभी ये सोचता हूँ कि जो ये पेशेंट होता है फीमेल सेक्सुअल मेडिसिन वाला, ये इतना डरा हुआ, सकुचाया हुआ, आपसे बात ना करने वाला होता है कि मुझे एकदम से एक राहत इंदौरी साहब का एक शेर याद आया और बड़ा एप्ट होता है इस पे कि लोग हर मोड़ पर रुक रुक के संभलते क्यों हैं? इतना डरते हैं तो घर से निकलते क्यों हैं? नींद से मेरा ताल्लुक नहीं बरसों से, नींद से मेरा ताल्लुक नहीं बरसों से, ख्वाब आ आकर मेरी छत पे टहलते क्यों? Sexual medicine, patient of sexual medicine is, hypoactive sexual desire and a sexual aversion disorder is extremely distressed. But still this person with distress cannot talk to you. So the evaluation, ये आपसे डरा हुआ है. These people cannot come to you. They can't talk to you. And they expect you to talk to them. So the evaluation is most simply done in the form of a questionnaire. So it's a very famous 5-question questionnaire. And the questionnaire is very simple. It should be with every gynecologist. And whenever she feels that this patient has a problem with hypoactive sexual desire, it is time that this questionnaire is given by the receptionist to the patient to fill in private. And the questions are, number 1, in the past, was your level of sexual desire or interest good or satisfying to you? Yes or no? Has there been a decrease in your level of sexual desire or interest? Are you bothered by your decrease in sexual desire or interest? Would you like your level of sexual desire of interest to increase? Now, these 4 questions are very simple. And once they are answered, if it is no, then one thing is clear, that the patient qualifies for the rest of the questions. And the rest of the questions are very simple because we would like to move out people in which psychology, drugs, or a surgical or emotional situation has brought them into this. So you would ask that, do you think there is any contribution into your current decrease by the following: operation, depression injuries, medication, drug, alcohol, pregnancy, sexual issues, partner sexual problem, dissatisfaction with your relationship or partner, or stress or fatigue? Now, if any of them is yes, then you need to look into the comorbid condition and you need to evaluate whether you would like to label this person as a person with hypoactive sexual desire. And it's a very simple thing to do. Now, moving on, next slide, please.
Yes, sir.
So once you have got this form filled, then, well, you'd like to know the relationship status. You'd like to know, how is the relationship with husband? How is the husband? What kind of a relationship does she have? Is there love, intimacy, or it does not exist? Is there anything which is bothering her? You'd like to take a history of abuse, verbal, emotional, physical, or sexual. You'd like to know if alcohol, tobacco, or illicit drug abuse is a part of the whole story of hers. Next slide. So you would also then take a history of the current health status. Does she have any problem medically? Any past medical history? Reproductive history, age of menarche, menstrual history, obstetric, infertility, contraception, everything which normally is taken. And endocrine history, because diabetes and thyroid disorder with hyperprolactinemia and androgen deficiency, these 4 things lead to this. You would like to see if there is any neurological disorder, hypertension, cardiac problem, psychiatric illness. You need to look into a few medications: antidepressants, hormones, anti-estrogens, antihypertensive agents, cardiovascular agents, weight loss agents, chemotherapies. All of these lead to decreased sexual desire. And any other conditions like breast cancer, psoriasis also can give these. So this is the kind of history which is very important for all of us to take. Next slide, please. Now, apart from this, of course, when the patient comes to you, you would like to do a physical examination, a proper gynecological examination to check if there is any anatomical problem. The tests are very few. But still, a few tests which could help us are those for diabetes, thyroid, prolactin, and testosterone. So these 4 tests, only 4 tests are there which would be needed. And this is in a very short, a kind of an evaluation which you could do very fast. We have this form with us, which along with the certificates which would be posted to you, we are going to post to you as a PDF. Dr. Deepak and Dr. Anita also will be contributing a few forms, which we will be sending to each one of you, which you could be using for your patients. So you have registered, your email is there with the company which is running the whole show, and they would be sending you the certificate along with the small PDF. So this will make it very useful. Over to you, Apu.
Thank you. Yeah, thank you, sir. Sunil, sir, before we moving to the next question, sir, I just wanted to ask you, like in your previous slide, you have said that serotonin and dopamine, these have a effect on the desire. So is it required, or is there any mechanism so that we can measure the serotonin level or dopamine level in the body? Or is it required, or it is not required? First thing.
Number one, this is the dopamine level in the brain.
Okay.
It's not the blood dopamine level.
Okay.
It's the serotonin level in the synapses. It's not that level. And what can be measured is the testosterone level. So a testosterone level in the woman and the man becomes very important, because especially in men, if the testosterone level is low, then giving them testosterone can help them phenomenally in their sexual function. And women too, when it comes to drugs, I will discuss how testosterone can be given to women so that this problem of hypoactive sexual disorder can be solved. Prolactin, of course, is a test which needs to be done, and thyroid and diabetes helps us a lot.
Thank you, sir.
Thank you, Sunil. Dr. Sunil, I have one question. You have just for the 5 questions. It is for the screening, I understand. This 5 question is for screening of the HSDD, right? So for detailed evaluation, is there any questionnaire available?
Those questionnaires I did not want to put up over here because that would be very long. And I'll print out the PDFs, and in fact, we'll prepare, as you had suggested to me, we'll prepare a PDF which we could send to every patient. Every doctor over here who could.
Just briefly, you can say about that detailed questionnaire. Just few words about that.
The detailed question would be about the drugs, the different drugs which are used. There would be a detailed about the kind of abuse which is there or not over there. It would be also about the hypertension, diabetes, all the problems which are present in the patient. And apart from that, the sexual problems in details which could be asked. So this would be a questionnaire which we could give. Giving a questionnaire becomes very easy because asking questions from these women becomes very tough at times. Yeah. They don't talk to you, and you could be spending about half an hour asking on one question. I don't have the patience as a clinician. Dr. Neeta, I'm sure, must be sitting there for hours, banging her head, because this is a tough job. I tell you one thing, Neeraj, men are very simple. They run to you and tell you, I am distressed. There is something wrong with my Bobby. Please do something about it. There is distress. And he will, if you tell him, I am busy for 5 days, after the 6th day, he will be there at 9 o'clock in the morning. But when it comes to women, and you take their history, it takes you half an hour. And after half an hour, when you tell them, do you want to get it treated? She sits for about 2 minutes to give you that answer, whether she wants to get it treated or not. It's a very tough job. So hats off to Dr. Anita, you for actually bearing with this patiently, but this is a tough line.
Thank you, Dr. So moving on to next question to Dr. Anita. Can you briefly say about what are the principles of management, and tell us about what is consent focus, what is cognitive behavioral therapy, and what is mindfulness. So just in detail, we want to know about this thing. Dr. Anita.
Anji, just a sec. थैंक यू डॉक्टर जिंडाल, बहुत ही सही तरीके से आपने एक्सप्लेन किया, बट मेरे थोड़े डिफरेंसेस जरूर रहेंगे कि भाई मेन इतने भी सिंपल नहीं होते हैं और विमेन हमेशा कॉम्प्लिकेटेड नहीं होती है. But nevertheless, we will take this conversation of this webinar. But friends, Dr. Jindal, Dr. Deepak ने इतने अच्छी तरह से आपको सारी चीजें explain की है कि मेरा job और भी ज़्यादा easy हो गया है. But as a clinician, friends, we have to remember a client will only be comfortable to you when you are comfortable with that topic. You have to be very open discussing about sexual functioning. You have to be very open and very ease about explaining, talking about intimacy issues. So what I always find interesting is we are clinicians. We learned anatomy. We learned physiology. What makes you think you're going to use words like, so your private parts, how do you feel in your private parts? So आपको नीचे कैसे लगता है, आपको वो करने का मन करता है, what is वो? So the first step of being a good clinician, of being a professional who is knowledgeable in the field of sexual medicine, is having your own beliefs and own judgment set and being very comfortable discussing this topic. And of course, there's no shame, because अगर patients आपके पास comfortably नहीं आ पाएंगे, if you would not become a vessel to your client to come and discuss their sexual issues, they have nowhere to go. And the second best place would to go is go to the Google doctor. And that's why we have so many problems arising. So the general principle of evaluating the female sexual functioning, Dr. Jindal ने अभी explain किया है कि अच्छी history लो, create a very comfortable environment for your client, have open, directed questions, no digging around the bush, friends. तो आपको वो करने का रात में मन करता है? No, आपको सेक्स करने का मन करता है? क्या होता है? Be very open. So here are some pointers. I don't want to go because Dr. Jindal और Dr. Deepak ने बहुत अच्छी तरह से ये cover कर रखा है. But a good assessment would be, what is the predisposing factors for this problem? What makes this condition aggravate? What makes this condition maintain? And when you have this three assessment, you'll have your proper intervention, और वो काफी target based रहेगा फिर. Also, Dr. Jindal ने cover किया है proper history about their relationship, about the partner, sex abuse, trauma, any of those things, evaluating them using those specific points in your evaluation will definitely help you. Now, he definitely covered this part, that it's not just a very easy task. It's not a person comes to you, she's not going to come and tell you, so I have low sexual desire. It is you as a clinician, it's you as an expertise, where you would dig into the complaints, dig into the history. So if I say it's not very simple, it is multifaceted, your treatment has to be multifactorial, multifaceted. So if in case you have a client who has psychological complaints and that's leading to the sexual problems, आप उनको direct करेंगे somebody who is really expert in that, a psychiatrist, a sexologist, a psychotherapist who deals with sexual complaints. अगर उसे कोई medical problem है तो आप उन्हें direct करोगे to Dr. Jindal, an endocrinologist, या फिर madam जो gynecologist हैं, and Dr. Jumani. So people who are, please refer them to a professional who would actually take care of these clients. So a good detailed history, very target-based questions can help you formulate or even help you to direct your clients. So this is a small semi-structured clinical interview where you, Dr. Jindal just mentioned chief complaints, duration. I talked about the precipitating factors, the predisposing, precipitating, and the maintaining factors, the family history, medical history, surgical history. And not to forget, we have to make sure that you're inquiring about these 4 questions. Does the individual experience complete or intimate loss of desire? That we talked about this initially, whether it is situational, it is generalized, it is these direct questions would definitely help. And since Dr. Jindal ne already covered kar rakha hai, I really don't want to go in deep. You can certainly read. What happened? Now, Interestingly, Doctor did mention about the questionnaire, the assessment questionnaire, but there are these three evaluation models which are available, and you can use it. You can design your questionnaire based on the allow model, the Plisset, and the Meeps model. So what are these models, friends? These models are they basically revolve around the biopsychosocial, and now, as I said, it's the spiritual aspect. They involve these four components, and you can formulate your history taking, and which can guide to the intervention. So the allow model helps you to ask questions, legitimize, limitation, open up, and work together. That means you're building a bond between your client, and there's a very unique bond you're building between the client and yourself. The Plisset model. The Plisset model is about permission, like means you're giving permission for the client to share his or her sexual concerns. You are giving the client a complete freedom that, hey, you know what, I know about this field, and I would this field, and I'm a vessel, so please share, and I'll be able to guide you. So you're taking permission from both the sides. You're giving information, you are giving them specific interventions which are going to help them in their intimacy and their sexual life. And you can also then give intensive therapy. So that is the Plisset model, friends. And then as a Meaves model, which is my favorite teacher, Dr. Brighton, who talks about the mind involved with the emotion, involved with the body, the energy, and spirit. So these models are available to you to make your history taking easy, your evaluation, your assessment very easy. So what is the goal? Why are we here today? Why are we talking about sex? And what we really want? Our goal should be very specific, friends. We want to improve their quality of life, specifically their sex life. We want to create a sex positive in between their relationship and a sex positive environment. Be that physician who talks positive about sex, not creating more dilemmas in an individual by talking about more negative things like, hey, it's dirty, raat mein karte hain, band darwaze ke andar karte, chi 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 chi. We are not there. We are here to create sex positivity, and that's what is my goal. Our goal is also to keep open mindedness, not bring about our judgment in our professional life or in our history taking or in our intervention. Because agar aap is tarah behave karoge, you're not comfortable, aap apni thought process dalenge, aap apne beliefs dalenge, so that's not going to happen. So improve the quality of life, creating sex positivity, open mindedness, and your treatment should be the client centered and goal oriented, and it has to show results. That's when the client will say, hey, this doctor understands me, this doctor is helping me because I can see the results, I can see the change in me, I can see that I'm becoming more aroused, more desired. Okay, so this is what your goal should be. Why is this showing up? So what is target based interventions, friend? So when we talked about all this time about the DSM-5 and the ICD, about low sex desire, about aversion. So if there are chief complaints, and this is just an example. So if there is decrease or loss or lack of desire in sex, and that is due to the vaginal lubrication, because if there's dryness, there is pain, there is uncomfort. So a target should be focused on what can you do if somebody comes with this complaint. Okay, somebody is not able to reach orgasm, somebody is not able to have arousal. Your intervention should be specific. How can you help this client? And though not within the parameters of this description of this webinar, but pelvic pain, if this client comes to you with pain. So let's understand, friends. So if there is discomfort and you dig more into it, you will get to know, okay, this person is experiencing pain. This person is experiencing because of the dryness, there is tear in the vagina, and that is causing pain, uncomfortability. So you want to treat that first. So target-based interventions. If the client has dyspareunia or vulvodynia, as a professional, hopefully you can read a little bit more and understand what are these conditions, and they can certainly affect the desire. They certainly affect if the desire is affected, arousal, person is not aroused. If because of the pain is not aroused, the female will not have desire. And also non-coital sexual pain disorder, you have to understand these concepts and go for a target-based intervention. I talked about what is a predisposing factor, precipitating and perpetuating or maintaining factor. So if was this person, as we talked about, if this was a lifelong condition or acquired. So if this wasn't a lifelong condition, what predisposed this concern? How does this keep on coming up and up? Why does she constantly have no desire, or she has aversion? And what keeps on maintaining this? So a good history taker, a good professional will always look into this, friends. So just quickly मैं आपसे बात करूंगी, what are the various factors which what are the various things which can affect the which can talk about these factors. Restrictive upbringing. If this person has strict ideas, negative views about sex, she's not going to enjoy sex. So as a clinician, you need to know that this can be a predisposing factor. I grew up in a family where we did not talk about sex. We did not watch TV together. We did not watch movies. All my learning was Shah Rukh Khan's movie and my favorite Salman Khan's movie. So there has been certain learning in my life also. So talk about get to know about the predisposing factor. Is it this client's restrictive upbringing? Was there a relationship problem, or is she right now having a relationship problem? Any traumatic incidences? Lack of knowledge. Friends, come on. We know that how much can this affect a person's sexual functioning? No sex education, lack of knowledge. All knowledge we get is through Bollywood movies, yeah, fir pornography. So incomplete, incorrect, or inadequate knowledge. What maintains this condition to this client? Is it the anxiety? Is this person having performance anxiety, or is this having panics or depression? What is maintaining this problem? Is there a poor communication between this with this family or this couple? So what is maintaining this, and what precipitates constantly? As I mentioned to you about my client who couldn't have sex with her husband when he had a very bad sweat odor, is that precipitates her sexual low functioning? Or this person comes completely drunk, is abusive, is that what is affecting? So a good history and understanding of what are predisposing, maintaining, and precipitating factors. A beautiful flow chart, and I love this. So this kind of helps you, friend, to understand if this client has an organic or an inorganic condition. If the person, if you evaluate this client has organic condition, and if that's not your expertise, please refer to a professional who has that expertise. So taking a comprehensive medical history will kind of guide you if this person has a psychogenic etiology. So refer to a psychologist or a psychiatrist, a combination psychiatrist, endocrinologist, or just needs counseling. So let's go deeper into what are the various treatment modalities available. Uh-oh. So this is something which I think is very important, and that's why I have put the slide here. That simple interventions, friends. A simple when the person comes to you with chief complaints of low sex desire, even a good history taken can get you into understanding if this person has dryness, or this person has some genital issues like a pathology, and you can guide the client into if they need treatment for infection, you can treat the infection, teach them genital hygiene, educate them. If the client has a comorbid condition or a concurrent condition, depression, diabetes mellitus, hypertension, metabolic conditions. I know right now depression being so common, double-edged sword this is. Depression causes sexual dysfunctioning. Sexual dysfunctioning can lead to depression. So one has to have a good knowledge about the psychopharmacology of depression, because as much as I want to say, my dear psychiatrist friends have been, and in fact, I don't want to blame my field of professional, but even the primary care doctors, left and right, have been prescribing antidepressants. So if a person feels low, let's go give them antidepressant. And the sad part is the client then suffers a lot of side effects, because one of the very common side effects of antidepressants are low sexual functioning, low desire. And a good understanding of medication which are antidepressant but low side effect on sexual functioning are bupropion, buspirone, mirtazapine has been used, and here goes on the list. So if in case there is a client who comes to you and is on antidepressant, a good approach or a good intervention in that case would be either you reduce the dose and find other modalities to treat the depression, or change an antidepressant, or go on the lower dose. So there are certain things can be done. Now, why do I talk about self-image? Because I come across a lot of clients who have acquired low desire or acquired aversion because of their body image. And it is very important, again, friends, to make them at an ease, give them education that yes, down the line, age आगे बढ़ते बढ़ते आपका waist 28 नहीं रहेगा. Unless and until you put in a lot of lifestyle changes, there has to be some modification. So accepting your own body is very important. And healthy interpersonal relationship and intrapersonal relationship with yourself is a very important aspect for management of sexual functioning. So now this is just because we are tackling two topics here, which is reduced desire and reduced interest, and also since arousal is associated with it, there are very simple target-based interventions which can be used. One is the psychosocial support for any self-image issues. Very common strategy here I use with people are आप अपना कोई पहले का पिक्चर जो बहुत आपको पसंद है, you really relish that moment, take a nice picture, put it on your mirror. That is called a mirror, image therapy or a mirror therapy, which kind of boost the person's self-image issues. And this Dr. Jindal is going to cover, but simple things like vaginal lubrication, have a good knowledge of what are the lubes available, the silicone-based lube, the water-based lube, the oil-based lube. Be well versed with sexual topics. And also a very important thing to know is if you can read about the Kama Sutra, the various position, guiding the clients towards various sex position is also very important. Now, when we talk about desire issues or hypoactive desire, Dr. Friedman and Dr. Loeb Piccolo has given us a 4-staged model. So I don't want to go in deep, but let's quickly go through what are the 4 stages and why this 4th stage is important to you. So when I get a client, I always make sure I tell my client it's not going to happen in one sitting. It's going to take time. If you are ready to work with me, we can make this happen. But if you are looking for a quick fix, that is not going to happen, especially with me, because I focus more on the non-pharmacological modalities than the pharmacological modalities, completely accepting the fact that I have full knowledge in the pharmacological therapies available in the market. But I certainly do not believe in the practice of writing 5 medications and having the client go through side effects with a hope that I'm going to improve. So this 4-element sequential model for the desire and aversion, you can read more in detail in the references, but this basically initially starts with affectual awareness of one's body, awareness of the belief system, awareness of the cognition. That is, what does this person think about sex? What are the negative thoughts he or she gets? How comfortable is this person watching pornography? What beliefs do they have? Research says that people who have very negative beliefs about pornography or watching nudity have very negative thinking or negative judgments about sex itself, and then that boils down to a lot of sexual problem. So as a physician, you can use the umbrella metaphor, and आपने umbrella metaphor बहुत different तरीके से आज सुना होगा डॉक्टर जिंदाल and डॉक्टर जमानी से कि we are born to love, we are sexual beings, we have innate sexual drives. And if that, as a physician, you can have an umbrella metaphor by saying, आपके जो विचार है शायद आपको सेक्स करने से रोक रहे हैं, is becoming like a barrier. So with affectual awareness, you want to use things like an umbrella metaphor, make the client understand that we can bring this change if you can change your cognition and thought, and that is what is blocking your sexual functioning. A very important tool I just mentioned about, if it is body image, we use mirror therapy, but visualization. Sometimes it's just giving a client your freedom or acknowledgement, like visualize that you're having sex with that partner. Visualize you're enjoying an oral job. This is basically, this will help your client even to feel ease that yes, this doctor is ready to talk about sex with me, is ready to talk about the various aspects of sex, not just a penetrative sex. So this is a very important first step. So this is kind of getting introductory and preparatory into your intervention. Role play. Now, all this time, this client maybe had inhibitions, maybe then was not involved in sex, but a role play certainly helps. Role play, taking that initiative. Okay, let's go step by step. Can you make an initiative just to touch your partner in a more sensual and a sexual way? Can you go more into deeper touching the different parts of the body? So role play. So this is the first step. It's a preparatory step. Second phase is an insight oriented therapy. Insight is more digging into their relationship, digging into how they talk about sex or what perception they have about sex. Family of origin experiences, what are their religious belief? So digging and breaking each barrier, each myth can get you more closer to your more intensive therapy or more intensive interventions. So please do read what is an insight oriented therapy. The three words says it all: insight, orient, therapy. So these two phases are the preparatory phase for a desire disorder and also aversion. Thirdly, very commonly known as cognitive behavioral therapy. You want to look at the cognition, the perception, the thoughts, and how you want to change this behavior. So this phase is called the cognitive and the systemic therapy. This phase of therapy serves to alter the irrational beliefs that inhibits the desire and to identify and modify a relationship problem that are suppressing this desire. So we now go more deeper into our intervention where we are trying to tackle the belief, tackle the perceptions. I'm going to read this paragraph and you might know that this is something very commonly I come across. A typical coping statement might be, if I allow myself to enjoy sex, it does. This is like giving the permission. We talked about the memes and the allow model. If I allow myself to enjoy sex, it doesn't mean I am dirty or I'm bad, because people grow up with that perception. And Dr. Jindal mentioned that sex is bad. Dr. Jumani also mentioned sex is bad, sex is dirty, sex is sticky, secretory. People have all these myths, and giving them that permission, yes, it is not dirty. If you allow yourself to enjoy sex, to reach an orgasm, it's not a crime. You are allowed to feel that, and that is what is normal to have. Dig into the dynamics of relationship. So this is cognitive systemic therapy, involving the cognition systemic therapy, going into the relationship. The final element of treatment of low sex desire and aversion is behavioral intervention. So here we talked about the first step, cleared the myths, negative aspect, cleared the cognitions, preparatory phase. Now we go more in the intensive therapy, is the behavioral modifications. This basically includes more of sensate focus, skill couple training, sex therapy, as well as some intervention which will be specific to the disorder. We talked a lot on that part. So the slides will be available. Please go through it. This has a lot of information, and this will really help you to modulate or to navigate or to form your interventions. Now, what is sensate focus? Designed by our dear teacher, Master and Johnson. This is a very sensual, sexual way of tackling desire issues. It is non-demanding, and that's why it has, I must tell you that it has less failure, less relapse rate. So if followed in a very systematic form, this can bring amazing results. So this is kind of giving this permission to a client that sex doesn't have to be penetrative. It doesn't have to be demanding, that you have to please, you have to be present there to enjoy sex. It is all about sensuality, sexuality, and enjoying the pleasure. So the stage one is all about touching, giving permission to be touched and touching each other in a non-demanding way. Clients have their clothes on, so that's why the touch is enjoyable. There's no strict restriction that the clothes have to be removed. No. Second stage is you go further more into details about touching the private parts, touching the breast, touching the penis, touching the various aspects of various parts of the body. Stage three is when a permission can be given if the clients have the liberty of using clothes and not using clothes. And again, this is not directed to penetrative sex. I often tell my clients, sex is not about something going inside and boom, boom, the movement happens, and yes, I reach an orgasm. It's a journey. It's a pleasure-based activity, and whether it is penetrative or not, you have to find your own pleasures in that stage. And last stage is when a client can give permission depending on how this stage has happened. First stage, second stage, third stage, a penetrative or more involved sex can be allowed. So you see a client 2 to 3 times a week. You assess the clients, you give them a set of homeworks to go back home, give them a proper design intervention that suppose up, and this is what I did recently, and I just wanted to share, and I got amazing result with this couple who have had relationship issues basically related around sex, and it's been going on last 7 years. I created a timetable for them, a diary, where you ask what are the days you would want to have sex, you would feel, and they strictly follow that schedule. So बहुत commonly हम जैसे बात कहते हैं, सामने अगर नहीं रहेगा आप सोचोगे नहीं तो करने का भी नहीं सोचोगे. तो अगर if you plan a schedule, create a schedule for having sex, a sex date, this is called a sexual date or a sexual fantasy date. So when you have these on your plate or on your schedule, you would want to plan your date accordingly, plan your day accordingly. So drive induction is another model which can be used for desire issues and also in clients who have aversion. So how do you induce drive, a sex drive? I just mentioned about the desire diary. A good way to really get into this induction is creating a diary about what are your thoughts, what stimulates you, what areas of your body really makes you feel sensual and sexual. What movies do you guys watch together? How does those movies make you feel? What books, what magazines you're reading? So a deep dig into their lifestyle, their relationship, and then navigating them towards more sensual and erotic movies or magazines or lifestyle would help in induction of their sex desire. So women enjoy the fantasy break. So as I told you, these interventions or management cannot be done with just the wife. You need to have the couple involved. So I usually talk to the male client and I tell them, how about in a week, give your wife maybe 1 or 2 hours just to fantasize. And this is as somebody who has come to me and want this thing, want therapy for the desire, or want therapy for your wife to have increased desire, or she wants to have increased desire, or want to come out of the aversion. You create a plan and have a fantasy break. In a day, maybe a couple minutes or maybe in a half an hour, you think, you fantasize, or sometimes in a week. So drive induction module really helps in both the condition. Now, this is another intervention which is by a very good researcher, that is the orgasm consistency training. My clients.
Anika ma'am,
Huh.
Sorry to interrupt. Actually, we are running short in time. It's a wonderful session. So can you just wind up in a bit hurry way so that
Yes,
we can
I will.
cover whole the pharmacotherapy and other things, ma'am?
Yes.
Yeah.
So, friends, orgasm consistency training is again a cognitive behavioral intervention where you help a client, help the female client to achieve orgasm. And every time they're indulged into a sexual act or in sex, you guide the client or you guide the male partner so they can, he can guide the woman into an orgasm, reaching orgasm consistently. This is again the same thing, a cognitive behavioral module. An involvement of couples therapy, friends, cognitive behavioral couples therapy and emotion focused couple therapy. Now, what is cognition behavioral? You help in the in uh, treating the irrational thoughts, creating a behavioral modification in a couples therapy, and the second is you focus on the emotions. What is this client experiencing? So these two modalities are there. There are a lot of relationship strengthening modules, practicing behavioral strengthening, which is more focused on communication skill, sharing sexual talks, sexual fantasies. So this is, I'm going to rush through it, but communication skills is very important and can sometimes, you will not even need pharmacology when you have created a good bonding. Since we talked about aversion therapy and we talked about how it's a conditioned response, a professional who's trained into a psychological aspect of what is anxiety, phobia, or a conditioned response would know how they can break their cycle. So if you see an assault associated with sex can lead to panic and avoidance, but if you can change the perception about a person, about assault, about the sex, then this fear, panic, and avoidance can be deleted and the person can enjoy sex. So it is just, you change the classical conditioning. um, so these are different things. Please read and it will give you a good information. Systemic desensitization, especially in aversion therapy, you grade a desensitization process and help the client to come out of the fear of sex thoughts, sex genital contact, fear of pain. So you can create a systemic desensitization staged module which can help the client come out of the fear and can accept enjoying sex. And this is called the behavioral desensitization hierarchies to create intimacies. And there I go to my friend, Dr. Deepak. Thank you so much, but here it's all yours, pharmacological therapy.
Thank you. Thank you so much, ma'am. So the bottom line message is that after the investigations, when we are asking about the history and everything, the diseases, the counseling part and psychotherapies have a very important role. So we move to our the next question that is very important, that is the drug therapy and the pharmacotherapy. So I invited Deepak Jamani, sir. Sir, please enlighten us with the pharmacotherapy part of HSDD.
Let me speak on pharmacotherapy. I'll be very brisk about it.
Yeah.
Before we start the pharmacological treatment, what we need to understand, we need to completely control the metabolic part. We need to counsel for interpersonal, psychosocial, and behavioral issues. If the patient is hypertensive, she's on diuretics, prefer indapamide. If he's on beta blockers, prefer nebivolol. Other ORBs are always better. The pharmacological treatment resolve around these particular things. Let me go into the deep. The best drug which I have found is Levial or Tibolone, which treats climacteric complaints, enhances mood, sexual well-being, beneficial effect on the heart, low incidence of breast tenderness, no increased mammographic density on mammograms, no endometrial proliferation. It treats vaginal atrophy, prevents postmenopausal bone loss. A very good drug for postmenopausal hypoactive sexual desire disorders. A study done of 38 postmenopausal diabetic women showed with just 2.5 milligram per day, significant increase in sexual fantasy, arousability, and desires, etc. The another drug which we have is DHEA. We all know that DHEA is a precursor of testosterone, right? DHEA reduces by 60% during menopause. So it is beneficial to give DHEA supplements. And there have been beautiful studies saying that DHEA supplementation in hypoactive sexual, the positive results were these steroids may be effective as a treatment with HSDD if it is administered in at least 100 milligram per day and over a period of 1 to 2 months minimum. We have also tried PDE5 inhibitors. Now, what do PDE5 inhibitors do? They just increase the blood flow in the genital areas. So beautiful studies, but not robust studies. They've also shown that sildenafil is also very useful in increasing the response in women. But patients who are on antidepressants, for them, sildenafil has worked very well. Outcomes have been beautiful. Botox have been tried in patients with vaginismus with curative results. Flibanserin, a new drug which is 5-HT-A1 serotonin receptor agonist and 5-HT2A serotonin receptor antagonist. Violet study was done, which was beautiful, and they said in pre-menopausal women with HSDD, flibanserin 50 to 100 milligram once a day at bedtime was well tolerated and associated with statistically significant improvements in successful sexual encounters, sexual desire, etc., and all the scores were improved. Another drug which is there available to us is Vilesi, bremelanotide, which is now available as subcutaneous injection, even as tablet and also nasal form. Beautiful study. These are melanocortin 1 and melanocortin 4 receptor agonists. The active metabolite is melatonin 1. Increased FSFI desire, reduces distress. But these two drugs, when we try in our Indian patients, maybe because of the cost or because whatever it is, it works just as the placebo. Another thing is genital pain disorders, which is provoked vestibulodynia, vulvodynia, or vaginismus. Low-level laser therapy has been a treatment of choice which have been seen, and beautiful results have been seen. We need to make them understand that there are certain aging changes which are there. Teach them about normal aging changes. Teach them that they will need longer foreplay. And there are a lot of alternative forms of intimacy which we should tell them. They can use water-based lubricants or estrogen gels or patches for dryness. Bupropion has been studied and proven very good to be effective in the depression-related sexual dysfunctions and all that. So we have four things. If your patient has normal or high sexual drive and normal motivations, check the level of distress and contextual factors. If this is so, she's normal, having normal desire and normal motive. If she has low desire, normal and high motivation, assess the hormone profile, androgens and prolactin levels. This is libidinal dysfunctions. If she has normal or high sexual drive but low motivation, assess interpersonal relationship. It is just sexual dysfunction. If it is low drive, low motivation, assess for depression, biological and all relationships. We need to optimize the female sexual dysfunction with every therapy which is available, including pharmacological, sex, relation, remove the risk factors, and CBT, which has been. The newer drugs which are now available are Librido, which Dr. Jindal is going to talk about. Is a combination of sildenafil and testosterone, bucipron and testosterone, Librido. D-cycloserine has been wonderfully treated patients with HSDD. Oxytocin is a love hormone, is a cuddle hormone, is a love potion. Beautifully, it's available as nasal spray, which can be given. The hypothesis of women with HSDD is that before the treatment, the inhibitory factors overruled the excitatory factors. Now, with all these treatments which you give, sex therapy, education, all the other things, even the drugs, the inhibitory factors become less and the excitatory factors become more, and they enjoy good enough sex. Over to you, Apurva.
Yes.
Dr. Deepak, one question. Which are the drugs available in India?
All are available.
All are available? Flibanserin is available?
Yes, all are available. Some are not available in the regular chemist, but in Mumbai we have Royal Chemist, and certain drugs are available in the grey market at a lot of centers. I can send the phone numbers to you. And in flibanserin is now manufactured in India also by the...
You talk about all these drugs?
Except the D-cycloserine and oxytocin nasal spray is not available.
All over India,
I think, sir, now the drug availability is not much issue, because in the internet, I think every drug is available if it is present in any corner of the India, and they can purchase that. There are a lot of such drugs which are used in the sexual medicine are not available in my place, in my city. But when I prescribe it, the people, they order in online and they get it in the online. So I think it's now it's a benefit of the online.
But amongst all the drugs, the best is DHEA, and maybe Dr. Jindal will tell you about testosterone and sildenafil combination. and busicoron. They work very well.
And
Other flibanserin is
can you just
total failure. Bremelanotide, they need to take injections with the total failure.
thank you,
Sir, over to you, Sunil, sir, with a very important two drugs. One is the testosterone and second is the buspirone. Sir, you have to unmute yourself, please.
This is very interesting because in, I think, about 5 minutes, Dr. Deepak Jumani has spoken what would be spoken in an hour. It has been done so well about all the drugs, and there is no doubt about it that flibanserin is not the kind of drug which actually gives much results. DHEA is said to give results. I have not given it much, but hearing from you, I'm sure I'm going to start trying DHEA in all these patients. And injectable is absolutely a no-no. But testosterone gel, how I came to start using it is interesting. I had been using testosterone gel for a long time in hypogonadism, and especially in men who had the male menopause with a low testosterone level. And a lot of men who used to come to me who always used to say, our mood is down, don't feel like working, don't feel like having sex. My situation is, I just don't like things now. And life has become boring despite having everything. So in these kind of men, if you got a testosterone level done, you would find that the testosterone level is low. And if you gave them testosterone, and of course, it was not depression which they had, a lot of these men have improved phenomenally. So it's a beautiful drug. Of course, there are some precautions which need to be taken. But all these patients I gave testosterone gel. So about 1.5 years or 2 years back, for these ladies who came to us with hyperactive sexual disorder, and I came across a couple of papers of testosterone and also understood this testosterone thing. We started giving them testosterone gel, and 300 micrograms is the dose normally for the patch. But gel is beautiful, and what we started giving them is one actuation. And we also went through literature, and one actuation was equivalent to about 12.5 milligrams of the gel. Now, the only issue, we went through the whole of literature. The only issue which this was that, first of all, when they read it was testosterone for use of men only, they would normally come back to us initially and discuss with us, but it was more important to explain to them in the beginning itself that this is testosterone, a male hormone. This male hormone is used for the sexual desire. It is the main hormone which enhances the dopamine in the brain to enhance the sexual desire. Once you have told them and you have given to them, we must have treated about 15 to 20 patients till now. And in most of these patients, the compliance was well. I think in one patient, we saw some hirsutism for which she had to stop. And on giving them to 3 to 6 months, especially those patients who had already understood maritally of having been counseled, the results of testosterone were good. Can I have the slide, please? Apurva.
Yeah, sorry.
Now, the only issue is that the long-term studies of, now this was a beautiful slide, no, previous slide, please, previous slide. If we look at this slide, we would realize that buspirone, which is a drug, it leads to, it's a serotonin 1A receptor agonist and a presynaptic dopaminergic receptor antagonist. So what it actually does is decreases the serotonin and increases the norepinephrine and dopamine, which is needed. The same thing which Dr. Jumani had a beautiful slide. It was an amazing slide in which basically it is decreasing the serotonin and increasing the dopamine. And similarly, the other drug, which is bupropion, this drug is a reuptake inhibitor of norepinephrine and dopamine. So what it does is it again increases norepinephrine and dopamine in the brain. So all these three drugs does the same. However, what testosterone does is it has an androgenic action and it has a neuroplastic functional effect on the prefrontal cortex in the brain. So because of this reason, the role and the action of testosterone is different from the rest of the drugs. So now what happens is, so you have a drug which is working at one place, testosterone, and then you can combine it with other drugs, just like Dr. Jumani had just said. And the combination of this drug, next slide please. So first of all, I had spoken to you about this, but treatment is normally, you've got to be very cautious that if you're giving testosterone, if there is no effect, in 3 to 6 months, please stop it. And we do not have a long-term safety effect for breast cancer and cardiovascular. Next slide, please. So these are very major studies which have been done. In most of these studies, there has been an improvement in the sexual desire and versus the placebos, and side effects have not been too much, especially in the dose in which we were giving. Next slide, please.
Yes, sir.
So over here, if you see, you have different combinations. There's a combination of bupropion and tazodone. There's testosterone with sildenafil. There is testosterone with buspirone. So these combinations are basically because of the fact that testosterone is acting on a different area and the other drugs are acting on another area. So these combinations in a lot of studies have shown to be better than placebos, but only after giving to a patient you would know whether it is working or not working well. I have used testosterone as a drug, and in a lot of patients, it is very useful. Next slide, please. So bupropion is a norepinephrine dopamine reuptake inhibitor. It's an antidepressant. It is also used to bring in cessation of smoking. It's a drug for that. 150 to 400 milligram per day is the dose. Side effects are there, and about a very large study of 2,400 people, about 10% had to stop the drug. But this drug is quite comfortable from what I have known. I've used this very little, but Dr. Jumani must have used it a lot, so he would give us a better idea of this drug. Next slide. Buspirone, of course, I have used because it's a very simply and a very cheap drug available in the market, and it's not expensive at all. Especially I have used in those patients who have anxiety. So as an anti-anxiety drug, if I've given buspirone, 5 milligram 2 or 3 times a day, it's very well tolerable. There is very little difference. And I think this is a good drug to be used in those patients who have anxiety. Next slide, please. And that's about all the way I would summarize for the drug intake of these patients.
Dr. Sunil, I just want to ask one question. Which type of patient you will put on testosterone or buspirone? Is there any particular class of patient you would like to put?
Yes. I would normally, first of all, after taking a history, I would like to take an intelligent patient to be put on testosterone. A patient who basically understands that this drug may have side effects. Number two, in case it doesn't function for 3 months, it would need to be stopped. I would look for a patient who doesn't have any kind of a breast cancer history in the family, or a patient who has some kind of a cardiovascular episodes happening with this patient, because I like to be very, very conscious of the side effects with these patients. And of course, from the very beginning, just like in this whole program we have spoken about, that we should be sure that the rest of the things like drug intake, medicine intake, family problems should not be there. It should be hypoactive sexual disorder where actually there is need for sex for these people.
Sir, I just wanted to ask one question, Sunil sir. Is the dose of the testosterone for both the male and the females are the same?
No, they are very different doses. For a woman, it is only one actuation, while for a man, it would be about 50 milligrams per day for hypogonadotrophic hypogonadism, which would actually be 2 actuations in the morning and 2 actuations in the evening. And in fact, let me be honest, 10 milligram is the dose, but what we get over here in India is Androtas gel. Now that gel has 12.5, and that's the reason we give 12.5.
Okay. Why I am asking you, sir, because many a time when we prescribe, we got the dose of, basically we are using till now, most of us are using testosterone for the male partner. and the female is not very freely available in the market. That's why I was asking about this question.
How to use gel?
Yes, sir.
Dr. Vinay, how to use this testosterone gel? Means where it to be applied?
So testosterone gel is, see, it's a bottle. The moment you press, whatever comes out is one actuation. One thing, it's a beautiful question because it is not to be used on the genitals. It is to be used on the skin. It could be the arm, it could be the abdomen, but it is to be used on the skin and let to dry. So it's very important, and of course, the patient has to be told it is not to be used on genitals. They have a very, very strong issue that they have to take it and use it on genitals, especially the men. Men feel that whatever they rub, Aladdin ka chirag jalega. So एक अजीब सी चीज है. That is the reason that I always feel that even women and men have to be told that it is to be used on an unabraded skin, which is healthy.
Sir, here daily or testosterone gel in which dose? Daily or how
Daily.
much?
It's a daily dose.
Okay.
It's a daily dose, single actuation to be used over here.
Okay. And how to monitor such type of patient? What to monitor?
Yeah, in the males, it is very important to monitor the PSA of the patient. Prostate specific antigen, which becomes very important from the prostatic.
We are talking about HSDD. So
yeah, but for these patients, normally, see, it's very difficult to get a free testosterone and a good testosterone, I would say, assay in our country. Very difficult. It has to be calculated actually. So what I personally feel is I personally do not get too much. I get one testosterone done initially, one testosterone done after 6 weeks. But normally, more than that, the feeling and the sexual desire of the patient has to be questioned. And if the sexual desire of the patient is good, it needs to be continued, or you have to discontinue it. That is what is important.
no, but I'm talking about which side effect you will look for. If you
Well, the patient, the short-term side effects the patient has is hirsutism as well as some pimples at times. This is the first thing which patients get. Hair and this thing. This is the first thing which patients get, if at all. And patients normally do not get it before about 2 months of usage of this. So if within 6 weeks the patient says that there is something which they feel very happy about sexually after using testosterone gel, then we would continue it. But normally if it doesn't go ahead for 6 weeks or 2 months, we stop it.
any long-term effect, side effect? Any long-term side effect of testosterone?
Long-term side effects of this are breast cancer and cardiovascular side effects, but they have not been evaluated fully for females. This is the problem. In men, of course, prostate-specific antigen and prostatic cancer can be there. So it's not to be given in men who have a higher PSA.
So now we move to next question for Dr. Anita. Yeah.
Neeraj sir, actually, the technical people are saying that it's already we have crossed the time.
Okay.
So I think before doing that, can we have the interesting, because I think we almost cover each and everything. Can we have a very interesting session in a very short about the very interesting cases in just a few lines from each and everybody of the faculties? And one more thing, that we have got 134 questions till now, but I have read each and every one them, and luckily our faculties answered almost everything about that which is related to the topic. So we are don't going into the each and every questions because we already covered that. And sir,
stop the share, slide share, please.
Yeah, yes, sir. Sorry. Yes, sir. So Neeraj sir, can we go that session where we can have that?
Yeah, only one case, interesting case, because we don't have much time. So one or at least two cases. Interesting cases.
Should I start with the case?
Yeah, we start with Dr. Anita.
Sir, Deepak sir wants to say something. Deepak sir.
Should I start a case? Yeah. Should I start a case?
Yes, yes.
Okay, sir. Okay, sir. Yes, sir. Sure.
This is a real-time case. A 36-year-old housewife of Muslim having 2 kids, 14 and 12 years old, presented with a history of low desire, decreased lubrication, decreased orgasms, but she didn't have any pain during intercourse. brought to me by husband who has no sexual dysfunctions, no relevant medical history, has very good erections, etc. On questioning the partner, I found that she was not interested in getting more children, which her husband wanted. And also she had some depressive symptoms. She is saying that he was so aggressive, he used to drink and he used to have so hardcore like thing, So she hence avoided sexual intercourse. So how do we manage this? What we did is, I referred her to the obstetric gynec and the psychiatric department and got her hormone assays done. OBGYN reported normal except some candidial vaginal infections, vulvovaginitis. Psychiatrist referral informed me that she was having mild depressive symptoms. The lab showed that she was anemic. She had diabetes. Fasting sugar was 184. Postprandial was 286. And HbA1c was 8. Her thyroids were normal. Other hormones were absolutely normal. But she had raised triglycerides and LDL 320 and 174. Liver functions were normal. And also she had low vitamin D and B12. So how did we manage it? So the diagnosis was definitely hypoactive sexual desire disorders. We did the counseling and advised her on lifestyle modifications. Husband was also counseled for various things. We started her on metformin and SGLT2 inhibitors. We put her on rosuvastatin because her lipids were haywire. We gave her vitamin D supplementations. We put her on methylcobalamin, 1500 micrograms. Also gave her bupropion 150 milligram once a day for 6 days. And then we increased the dose for the next 6 days onwards. We also gave her DHEA 100 milligram for 2 months. And we gave her candid ointment and talc with itraconazole 100 mg and called her for follow-up after 4 weeks. After 4 weeks, believe me, friends, her sugars were under control, lipids were normal, her depressive symptoms reduced, her urge to have sex regained. Advise her to follow birth control measures and don't let your husband to feel rejected. That's it. Over to you.
Yes, sir. Anita, ma'am.
So I don't have a slide for that, but
Definitely, ma'am. You can speak it. Yeah.
A very interesting case recently referred to me by Dr. Rupin Shah from Lilavati, and young client, low sex desire, lack of fantasy. And Dr. Rupin Shah referred him to a psychiatrist because she showed depressive symptoms. And this client came to me, and of course, Dr. Jindal, I spent 2 hours with the client with detailed history because I didn't want pharmacological therapy for her. But after doing the investigation, after doing the lab testing, the client had low vitamin D, had all his what am I saying here? All the vitamins were low, mineral counts were low, severely anemic, severe load of college work, severe load of work, because the client wanted to start her own startup, wanted to start a business, and there's a severe load, lack of sleep. So what I suggested to the client was simple behavioral modification, lifestyle changes, sleep hygiene, exercise regularly, vitamin supplements, okay, no antidepressants, because she did see a psychiatrist who immediately after 15 minutes of history taking said, you are depressed, you need antidepressants. So no, sleep hygiene, lifestyle changes, proper diet, okay. Severe, since the client was anemic, we gave them vitamin supplements, vitamin D. And yes, the client is in Canada, back with the partner, with proper sex desire, enjoying sexual behavior every single day. So just bring into your notice, friends, do not bypass your history taking. Spend time with your clients, and the client will itself give an history or will itself talk about what's going on in the client's life. So even if the client had a lot of stress about college work, about starting a startup, we kind of gave her a schedule where she could spend more time, productive time in sexual behavior. Of course, having a time for her passion for work, career, and everything. But yes, certain behavioral changes, lifestyle modification, no whatsoever antidepressant, back to sex life, actively enjoying sexual behavior, good student, back to starting a startup. So yes.
Thank you so much. Sir, over to you, Jindal sir.
We actually, it's very crazy because such beautiful cases have been said. Dr. Jumani had so many slides, he has so much to share. But we, most of the times, since we treat fertility, a lot of patients come to us whose fertility is there, which is sexual in nature. So we get a lot of patients when they've not had a child, and they would come to you and say, we don't have a child for a long time. You check up everything and you find and you realize that everything is great with them. You take a history and you realize that they do not have sex. So a recent patient I will talk about, but there's so many patients. This patient came to us that, well, there was ovulation problem, and she gave a history that she just does not want to have sex. And because of that, her husband and her relationships have gone haywire. She started suspecting that he has relationships with other women, and she's become angry towards him. And I asked him and talked to him and asked him what's the problem. He said she just does not want to have sex. And then because of this reason, she suspects, since I'm not being able to have sex with her, that that I have relations outside. And because of this problem, our marital life has gone haywire, more because of sex than the child. So both the investigations done, which we routinely got done, and prolactin was high, very high. Got a CT done of this patient, found a microadenoma in the pituitary, and prolactin was high. Put her on cabergoline, put her cabergoline not only for ovulation, but also for the disorder she had. Sat down with her, talked to her, and realized that once the drug had been given, cabergoline, the rest of the things were there. The husband, of course, was very supportive, a very nice guy. The things went back to normal. Ovulation started, they were able to have sex, and they probably will have a child soon, naturally. So this is the beauty about sexual medicine. People don't ask about it. People don't look into it. And in fact, this woman was saying that probably he has a relationship with the maid servant. So I get the maid servant checked out every time and I have to do all the work. That has become a bigger pain. So it's a whole story which is so different. So that's the way sexual medicine is. And can you imagine, we've had about, sir, 2.5 hours of discussion where we didn't realize how the time flew away.
Yes.
Correct.
If we want more,
Yes, yes.
we want more.
Minutes, if you could give me.
Yes.
If it is possible, 10 more minutes.
No, Deepak, it's very late. Apurva, should we wrap up the?
So there were two things which Dr. Neeraj, I just wanted to talk over here. Since you and I had decided that we are going to, I mean, you are giving, and the committee is giving a certificate to everybody who has attended.
Yes.
So when that certificate is given, I would also request Dr. Anita and Dr. Deepak to, we were planning to create a small booklet of the questionnaires which every doctor should give to their patients, which will be very useful. So if we could formulate in the next 2 days, and that ebook could be sent, or that PDF could be sent to every doctor with the certificate, I think that would be very useful.
Yeah.
And could you please announce the next program which we have, Dr. Neeraj?
Our next program is on 23rd of April, 6 p.m. And we will send the link and everything to all attendee by the mail. Along with the certificate, we will send the details so they can join our next program. Right? And our next program is on the orgasmic disorder. Session 2 is on orgasmic disorder. So,
Also, Neeraj Bhai,
link and everything.
Neeraj Bhai, if we could write a synopsis of today's discussions, what we had with all three of us, it will be a good, summary of all the three things. It will be a good ready reckoner for everybody, because many people fumble with DHEA, fumble with testosterone and how it is to be given, why it is to be given, especially the therapy part of it and the symptomatology. That will be very good, let it go as a ready reckoner for them.
Correct.
Yes, we will definitely make it available, and we will put it on the Foxy website under our committee, so anyone can read about that anytime in future. So we will make a video as well as the ready reckoner available, and we will put it on the Foxy website under our committee banner. Okay. So they can refer at any time in future also.
Yes.
Because it will be on Foxy website.
Yes, sir.
Thank you very much. In fact,
should we wrap up?
Yes, sir.
Can we have the streaming, the audience streaming stop, please?
One
Yeah,
minute,
Mr. Rohit.
one minute,
Please stop
Dr.
the streaming.
Sunilbhai, we have to give,
Okay.
complete the vote of thanks before we.
Yes. Vote of thanks before.
Yeah. So I'm thankful to all the three masters of our Dr. Deepak Jumani, Dr. Sunil Jindal, and Dr. Anita Syam for sparing their valuable time, and it was a wonderful, wonderful discussion. I'm sure that everybody who attended this session must be benefited by it. And heads off to you to this detailed presentation. I know it's very, very tough to make this presentation, and from your busy schedule, we appreciate that you spent a lot of time in preparing this. And I'm thankful to our proxy office bearer, our President Dr. Alpesh Gandhi sir, our Vice President Dr. Ragini Agrawal, and our Secretary General Dr. Jaideep Sang for giving us this opportunity to host this masterclass series, and especially Dr. Alpesh Gandhi sir for being there as a chief guest and honoring us. And I'm thankful to my co-moderator, Dr. Apurba. He's a very hardworking guy, and he's like my right hand. Whatever I want to do, I will tell him. And
sir, you are the inspiration for me, sir. Always.
No, I'm instrumental, but without you guys, I'm not possible to do such type of program.
Thank you.
You are
Thank
my
you so much.
right hand. Without you, I can't do anything.
It's आपका बड़प्पन है, sir. Thank you so much, sir.
And thank you to all the attendees who have attended this program, and I hope they have benefited by attending this. And special thanks to our sponsor, INTA Siva Division. Without them, this is not possible. And especially Lai and Rohit, who were there from the beginning to formulate the program, to finalize the program, and to give this final touch to the program. So thank to all team of the INTA Siva Division for your support. Thank you. Thank you very much.
Thank you, sir.
Thank you very much.
Thank you so much.
Thank you all.
Thank you, everybody.
Yeah, Mr. Rohit, we can go offline now.
Yes.
Sure, sir.
Yeah, we are offline, sir.
Okay. So
Well,
how much attended?
By Neeraj Bhai,
Yes.
what we have seen is hypovitaminosis D